This
MRCOG. I
conference will
welcome
now
you
be
all to
recorded.
this session, which is about how to get through, how to prepare, and how to get through Part 3 MRCOG. In this presentation, we will be talking mainly about how Part 2 is different from Part 3, and what is the organization of Part 3 practical examination, like what is its anatomy, what is its physiology, and why do people fail, or how not to fail. And also we will talk about what is the organization of ONG training in UK, and how do they assess you in this examination, what is the organization of this exam, what are the domains. We'll talk we'll discuss about briefly about those domains. And then we will also talk about the course that we are offering from beatmrcog, the outline of the course, the aim of the course, what are its pros and cons, and in the end we will discuss one case scenario, one task, and I'll encourage people to volunteer for it. So we have total 11 people have joined, and I think we should start. Part 3, or the MRCOG examination, it remains one of the most internationally recognized degree or postgraduate examination in its specialty. It carries a lot of prestige worldwide, and it certifies, if you are MRCOG, it certifies that you have very high standard in clinical skills. And as a MRCOG candidate, or as a member of RCOG, you can practice in any of the Commonwealth countries, namely Australia, New Zealand, Canada probably, and UK, and there are some other countries. So just a minute, yeah. So just to emphasize how it is different from Part 2. Part 2 focuses mainly on knowledge and also on applied knowledge, whereas the Part 3, it aims to address one of the most important aspects of what is showing on your screen, which is the Miller's educational skill triangle. And Part 3 is mainly showing how you know, more than that, knowing how you know what you know, and showing how, and sometimes even doing. So if Part 2 is, let's say, at the bottom of and you know how, Part 3 is showing how and doing how. So communication is the key, and it is the central to this examination. And in this examination, communication is assessed in several domains, and we will touch upon those things. So communication is the key to crack this exam. And to crack it in first go and in a short time, you have to have a strategy. A strategy which just doesn't limit itself to like how to prepare, where to read from, how to read, how many times to read, how many tasks to do. Well, it also should include like when to appear. Should you appear immediately after Part 2, or should you take a break and have more time? So I think there are both pros and cons for both approach. I am particularly inclined, as I did myself, I would like to take it immediately after Part 2, because you are fresh, bubbling with knowledge. You have gone through all the guidelines, you've gone through all the talks, and you will carry that knowledge with you, and you won't waste time in refreshing that. That is one. And you're highly motivated. You have cracked one of the most difficult examinations. So, but even if you're going to take a break, that's not a bad idea. Secondly, where to appear? Well, everybody would love to appear in the country of their origin, but it's not possible for every country. So we'll come to that later on. How can you organize that? And then how to prepare? Well, the most of this presentation, like 95% of this presentation, is how to prepare for Part 3 MRCOG. Now, before we go into the details of exactly we should first have some knowledge about how this is organized. So if you're looking at the November diet of Part 3, for any diet, I think the total available seats, they hover between around 100 and 850, maybe 830, 850, something like that. And I'm not aware of the distribution, how much for UK candidates and how much for overseas, but I'm sure they get a preference. The application date is still not available, but you should keep looking for the exam date as well as when the registration opens on the RCOG sites. Now, the maximum number of circuits, will come to what is circuit, is run in London, and in India it is conducted at 4 metros: Kolkata, Chennai, Delhi, and Mumbai, and they pair 2 of the metros for 1 day, and 2 metros they run it on an alternate day. And other option in Southeast Asia, Singapore and Hong Kong, and probably this year also. This year they might conduct it in UAE and Egypt. For those who have countries different than these, probably they might be conducting online this year. As far as India is concerned, I think most likely they're going to conduct face to face, and it is the online exam. You can get the details on their website, and if it is conducted and if you're going to be appearing online, they will give you all the details. Now, just a brief description how the ONG training is conducted in UK. So after obtaining the undergraduate degree, which is MBBS in UK, they undergo 2 years of foundation training. And the foundation training is similar to what we call internship in India and maybe probably in other countries. So over here, we have 1 year of internship. They have 2 years of foundation course. After that, they apply for the specialty they want to get in. And if they get into the specialty of ONG, as you can see, the ONG training totally, it's 7 years long. And it is divided into 3 parts: 2 years of basic training, and then 3 years of intermediate training, and 2 years of advanced training. To move from ST2 to ST3, one must clear part 1. So it is a requirement to move from 2 to 3, you have to clear part 1. To move from ST5 to ST6, you must clear MRCOG. So you have to clear part 2 as well as part 3 if you want to move from ST5 to ST6. So it is very important for you to understand here that the part 3 examination is set at the standard of a competent ST5 training. So it's, it's like, what is a competent ST5 training? So they define a competent ST5 training as one who can manage most of the scenarios in delivery suite or labor room, and most of the gynecological emergencies, and can run a general gynae clinic and a general and an antenatal clinic with minimal or indirect supervision. That is a competent ST5, and this exam is judging a competent ST5. In terms of South Asian countries like India and Pakistan and Bangladesh, I think the kind of structure we have, they will be judging. We will be somewhere at the level of some senior resident. So the terminology is ST5 over there, and another terminology used is registrar. Now, the format or the anatomy of this exam. The part 3 exam, it consists of 14 tasks. 14 tasks which are linked to the 14 knowledge-based modules of the UK OBG curriculum, and we have the list on the right side. These are the knowledge-based modules to which these 14 tasks or 14 stations will be linked, and each of the modules will be assessed in terms of 5 domains. Again, we will discuss those domains in detail. And examination consists of a circuit of 14 tasks. Now we call it a full circuit, contains 14 tasks or 14 stations, and time allotted to each task is 12 minutes, 2 minutes to read the instruction and 10 minutes to complete the task. The practical arrangement. So as we know, the set of 14 tasks on a given place on a given time is called a circuit. The tasks in the morning and in the evening session on a given day are same. But the tasks may vary, they usually vary on different days. But see, the point is, I'll come to the standards and how do this judge the standards, how do they do the marking. Okay, the type of task first. So there are mainly two types of tasks: the simulated patient or a simulated colleague task, and the second one is structured discussion. As I said, 12 minutes is allotted for each task, 2 minutes to go through the instruction, which is out of the booth. If you're appearing face to face, you will have 2 time to go through the instruction. There will be a pencil and pad. You can note down the important points if you want to. And then a buzzer will sound off and you will have to enter the booth, and then you have 10 minutes to perform. So, and there is no break in between. So you will be constantly moving from one booth to or one task to another task. And this total duration of exam is just below 3 hours. Exactly, to be exact, it is 168 minutes, out of which 28 minutes are for reading the task and 140 for performing the task. In a simulated patient task, candidates interact with an actor or a role player who are trained as well as fully briefed about the role they are going to play. They have full details of the case scenario, and they also might ask or will ask some scripted question to prompt you if needed. In some tasks, these role players might show they might show some emotion such as anger, anxiety, distress, or even doubt or lack of confidence in you as a doctor. But that is okay. You should not ignore it, but you should address it. But it should not sort of distress you. It should not let it affect your performance in the task, because whatever they display, anger, anxiety, or distress, they will never display extreme behavior like yelling or shouting, and they will not leave the station in those 10 minutes. So you have to gather yourself, gather your wits, and address. Don't ignore. Address that issue. In the simulated patient task, you will have one examiner, or most likely you will have 2 examiners. And the role of examiner is very passive in simulated patient. You can just ignore them. Rather, you should ignore them. They're like fly on the wall. They will be passive. They will not show any kind of. They'll have a neutral facial expression, and they will be just busy marking, observing you, and just writing down continuously in their sheet. So the marking is going on in real time. It is not done later on. It is done in real time as you're performing the task. In a simulated, in a structured discussion task, you interact directly with the examiner, and the examiner has all the details, instruction about the task that you're going to perform, and they will have a list of questions, so that when you're straying off the mark, they will ask those questions, and you can move on, so as you cover the entire task without wasting time. They may give you, if you ask them, they will give you further information, just such as if you want investigation report or further clinical details, they will give you when you ask them. It's like Viva in South Asian parlance. If you talk, it's appearing in a clinical Viva. Now the examiners, there are 2 types of examiners: clinical examiner and lay examiner. Clinical examiners are either the fellow of RCOG or they are the member of college, full-time consultants. They get selected based on a appointment basis, and they undergo rigorous training and briefing before they judge you as examiner, so that there is no bias from task to task or circuit to circuit. Also, they are trained in equality and diversity, because a lot of overseas candidates are coming from South Asia, Southeast Asia, from Middle East, and from North African countries. So they are trained to overcome those biases, and they are trained in equality and diversity. And lay examiners, they are representative of the general public. They will be present in at least 4 of the simulated patient tasks. Now, their job is to basically not judge your knowledge, it's to judge your communication skills. So they will be marking you on communication skills. And another thing, they do not interact with the clinical examiner. Now, coming to the marking, I've already told you it is done in real time and standard setting. So it's one of the most notoriously difficult exam, I think 4 out of the 5 will not make it in the first go, and it is widely perceived that the examiner there are there to fail you. The job is to fail you. Well, that's not what they want to do. Their job is to identify a competent ST5 candidate. That's what they want to have, a competent ST5 candidate. They don't want to have an excellent, brilliant. They are not looking for brilliant or excellent training. They are just looking for competent. Now, important over here is to understand that I think a lot of candidates who appear in, particularly overseas, who appear in part 3 are senior people who have their independent practice, or who are working at senior level in government setup, and they are doing a lot of complex tasks, managing cases. They're consultants, and they forget, they sort of, they don't forget that thing, and when they appear in the exam, they forget that they have to, sort of come to the standard of an ST5. So I'll come to that. Patient safety, you have to call for help. So it is important to understand, it is the ST5 that they are this judging or assessing, and this is called criterion reference. Both part 1 and part 3 are criterion reference against the level of an ST5 trainee, and I've told you what a competent ST5 is. Now coming to the standard, they say the standard required in any exam, whether it is November diet or the May diet. Diet is when the entire exam is called diet, and there are different circuit running in a diet. So the standard is such that even though the tasks may vary, the difficulty level of an diet of a circuit may vary, but the chance of passing is same whether you appear in November or whether you appear in May. How do they do it? They say that let's say that there is a task pertaining to preeclampsia. This is a very, this is something which we deal day in, day out, preeclampsia. So you're expected to know in depth about preeclampsia. So according to them, this is something must know in detail. It's a simple task, so the standard to pass will be high. Whereas if you get a task on, let's say, some pubertal problem, androgen insensitivity syndrome, or some very complex task, then the standard to pass this particular task will be set lower, and the standards are agreed upon before the exam. So the passing standard for each examination may vary, but the overall chances, whenever you appear, is irrespective of when you appear. And then they give marks, or they judge you as pass, borderline, and fail, and they numerical values given to them. For pass it is 2, for borderline it is 1, and for fail it is 0. So there is a numeric, they convert it into a numeric score, and then a global score is calculated, and based on that, and whether you reach the expected standard or not, you are considered pass or fail. Now coming to the task, as I said, each of the 14 tasks will be judged on these 5 domains. So let's start with the most important domain, which is the patient safety. It's called the raison d'etre of healthcare. It's a French word which means the very purpose of existence. So if safety is not there, patient care cannot exist. So it is the most important domain. But I have heard many mentors say that if you fail in patient safety, you cannot pass. But I think that's not correct, because I think I shared on Telegram a result card of MRCOG 3 where the candidate had not reached the expected standard in the patient safety, yet that candidate had managed to pass. So it is definitely the most important domain, but it's what they say is no domain is more important. It's like, it's not something indispensable, but you should give it a lot of importance. I'm not saying that you should fail in this, but factually, every domain carries equal marks, to my understanding. Now, patient safety, the GMC, the Journal Medical Council of UK, says, or it stresses, that every doctor should recognize his or her limits of clinical ability, and they should refer a patient or call for help when it is appropriate. However, that does not mean that you should call for help in every scenario. So the candidates who are not going to take any responsibility for decision making in any of the tasks, they're as likely to fail as a candidate who does not call for help or refer or takes help of a senior at appropriate time. So this is important, that you know the limit of your abilities. You have to remember that you are an ST5. Forget what you are doing in your personal life right now. In exam, you are an ST5. Patient confidentiality is paramount in caring for patient, and in UK, the patient information is protected by the Data Protection Act. You have to understand that the patient's relative, spouse, nobody can access the confidential information until unless the patient has consented for the same. So, and there is a Caldecott guardian in every trust hospital. It is also essential under the domain of patient safety that you understand the principle of mental capacity as outlined in the Mental Capacity Act, as well as Lord Fraser competencies. When a girl who is underage, like 13 to 18, she wants to have contraception, seek contraception, or she wants to terminate the pregnancy. You have to understand, I think everybody who has passed part 2, they understand it. So these are assessed under the domain, they may be assessed under the domain of patient safety. And you have also the patient safety also includes the respect for patient dignity at all times. So you ensure that whenever you're asking for intimate examination, you must ensure use of a chaperone. And whenever you're doing some kind of examination, you should ask for permission. Another feature of patient safety is respecting for patients' cultural and religious belief. And a glaring example that is always given is Jehovah's Witness. We know they won't accept blood or any blood product from a donor, even if it means death. But then you have to respect the autonomy of the patient. So you have to establish beforehand what will they accept. And the respect for cultural or religious beliefs does not mean that in UK the patient is allowed to break law. It is in context to the FGM. So it is a crime. We all know that. And you also have to understand consider the safeguarding issues if a woman has FGM and if there are dependent children or siblings. So you have to consider their safeguarding issues as well. Another domain is in the WHO's safe surgery checklist in NHS, all NHS trusts. This is practice. So you should be familiar with it. And the best way, see, we can mug up, we can do the rote learning of WHO checklist, but to understand it completely, I think the best way is to, you all must be practicing daily, you must be operating, is to incorporate this thing in whenever you operate. So sign in, time out, and sign out. Ask your floor nurse to say it aloud, every 3 components, and then it will be on your tips. Another feature is of safety that can be assessed or prescribing errors. They say that in UK, prescribing errors occur in up to 10% of all hospital admissions. And in obstetrics, there are particular concerns, issues about prescribing because of concerns for teratogenicity, transplacental transfer of drugs, excretion via breast milk. So whenever it will be judged, it may be judged. So whenever you have a patient, you are prescribing something, you just communicate to the patient. So I'm writing this prescription, this is baby safe, or in lactating one also. Apart from that, one particular task that may be judged under the domain of patient safety is the skill of triaging and prioritization. So you may have a task of handover in labor suite or in gynae emergency, where you will be given a list of 10 patients. They will have different scenarios from stable to very something really life-threatening complication, and you will be given a list of staff that will be assisting you. So you have to prioritize the most important cases, those who should be seen by the most experience and should have the least waiting time. You have to prioritize this, and this is also can be, so it can be just as applied knowledge, it can be just as communication with colleagues, but it also comes under the domain of patient safety. And the general medical also stipulates that a doctor should constantly monitor his work and try to improve the quality of his work. And to do that, you should have an understanding of how these processes, audit, these clinical governance process, audit, reflective process, practice, logbook, how do they achieve this improvement in quality, and how do they achieve constant monitoring? Now coming to the communication with patient and families, it is, as obstetrician, we have to communicate with patient, and in time to time we have to communicate with the families. It's a very fundamental practice for doctors. It's a very fundamental skill for all doctors in clinical practice. We as doctor need to explain to the patient what they're suffering from, the condition that they're suffering, and we have to explain it in patient friendly language. That is important. And we should be able to discuss the investigation in patient friendly language, and then come to a treatment option in a logical manner and for that particular patient, and finally should be able to take an informed consent. And the ability in obstetrics, the ability to very rapidly build a relationship or rapport with patients, particularly when they are very, they are in most stressed and most vulnerable, sometime in crisis like situation, like you're dealing with fetal distress and you require a cesarean section. So that ability to build relationship and rapport with patient in a very, very short span in a very crisis like situation, that is a skill which is particularly needed in obstetrics. So some tips for communication is, I think a lot of you have already been doing this volunteering for tasks. We know we should start by greeting, by introducing ourselves, by explaining our role and confirming name and age of the patient. And then you should start, you should set the agenda or the scope of the meeting by explaining that before we discuss your concern, before we discuss your what is suffering from your investigation or whatever it is scenario, I would like to ask questions, and then I will examine you, and then I may examine you, and then I'll discuss the investigation, and I'll discuss what exactly you're suffering from, what is the clinical scenario, and then we'll discuss the management options. So that is setting the scope, and then it should be done in a way which encourages the involvement of the patient. So it's, the Western people have moved from an era when the doctor used to set the agenda, and we used to talk, we still talk down our patients, but in UK they talk about equity of patient in their care. They are equal partners. So to be able to give them equal status in their care, you have to communicate with them in a way that opens them up, and they share their concerns and expectations. So it should not be your agenda only. They should be able to share their concern, expectation out of this meeting. And to achieve that, you have to work on your verbal as well as non-verbal cues. Active listening, what does it mean? Like face-to-face active listening means you are giving the utmost importance to the person who's talking to you. So you're maintaining eye contact, you're nodding and showing that you're following what you're saying, and making some encouraging sounds like, okay, I get it, something like that. And then you have to show empathy also. Empathy, an example is, let's say patient, you're in a labor suit, patient is in, you have to brief her about something, or need of cesarean section, or there is baby has passed meconium or something you want to do, and patient is in, it's just had contraction, it says she's in obvious pain. So you just need to wait, or at least offer that, can I offer something for pain relief, something like that. Or let's say a patient is waiting, has come for appointment, and the consultant had to leave for emergency, and you have all the patients to look for, and you got late. So patient will be in some kind of anger or agitated. So you have to understand that. That's empathy. And then in some situations like breaking bad news, you have to show an appropriate emotional response. For example, let's say you're going to debrief a patient about IUFT, then you can't be smiling, like you can't greet her with a smiling face. You have to show a solemn, you have to give a solemn expression. So these are some skills to improve your communication. And in modern day obstetrics, particularly everywhere, I think people work in shifts. In the UK, there is a 12-year shift for specialty training. Even consultants work on shifts on, usually they're on call, but on weekends they work on shift. So you have to, incorporate this handover culture, and you have to adapt yourself to the shift work and working with multidisciplinary team as well. So this means that you have to have the ability to communicate with medical, nursing, or midwifery colleagues very safely at handovers via the notes, or for both inpatient and outpatient, or with colleagues in primary care. And it's an essential skill for an ST5 trainee. You can be assessed. The task relating to the communication with colleagues could be writing operation notes, writing a letter to the GP, or writing a prescription or a discharge summary, and teaching junior colleagues. Now, the skill of information gathering, it includes both what is the information that you want to obtain and how to obtain that information. And this is history taking in simple terms, and taking history is one of the most first skill that is taught to us in medical school, and it remains the fundamental method of gathering information in order to construct a differential diagnosis and to develop an appropriate management plan. And a candidate, as a competent ST5, you are expected to elicit information from the actor by using a blend of mainly open-ended question and some closed questions. So, as an undergraduate, we teach our students to use a standard template which has a long list of questions so as to cover the entire obstetrics or entire gynecological scenarios. But as you become senior, as you go, practice more and more, you're expected to change, to evolve your history taking skills so as to demonstrate that you have that critical thinking process to understanding the pathophysiology. So the moment patient comes and tells one thing about herself, like let's say patient says I have pain in the lower abdomen, you have immediately have 4 or 5 list of differential diagnosis, and then that should those differential you have to rule in or rule out. So you have to use more open-ended questions so that patient is able to share their concerns. So this is all about patient-centric approach and history taking. Signposting, we all know it is important, particularly if you're asking something very personal question or you're very sensitive information. As I said in one of the tasks, taking alcohol or taking smoking is not something illegal, and so you need not signpost for this. Recreational drug, of course, it's not legal, and asking sexual history or about partner, that's a sensitive information and you should signpost. So as I said, history is something which we are taught at first skill that we are taught in medical school, and we have been taking history for such a long time, yet the candidates fail in the information gathering. Why? Because what are the pitfalls? Asking irrelevant question to that particular scenario and wasting time. So you should evolve. You should look at the scenario, and whenever it is written that you have to take a relevant focus history, you should take that seriously. Another mistake that people often do is repeating the questions. That is a bad thing, because it means that you are not listening to what the patient is saying, or you're like actively, if you're not making an eye contact, you're just looking nervously at your watch or looking at the examiner for some kind of appreciation or nodding from them. So you should avoid doing that. And Do not ignore cues from the actor. Sometimes the role player might be evasive, not answering to your question. So probably they are giving you cue that you are asking the wrong question. You need to ask something different. So don't ignore cues from the actor. Applied knowledge, well, see, the pure knowledge, like we all, since you have reached part 3, you have gone through part 1 and part 2. I'm sure you know a lot about anatomy, physiology, biochemistry, pharmacology, microbiology, everything. So this is, we know this is the bedrock of medical education, but pure knowledge it has a very limited role in the real world, in day-to-day clinical scenarios. The real importance of clinical knowledge is in understanding how to apply this knowledge in an individual patient. Given individual clinical findings, individual investigation, how to interpret those clinical findings and interpret those investigations, and then have a well-constructed differential diagnosis and develop a well-organized management plan. A simple example is, let's say a patient has, for HMB, the NICE guidelines say the first line treatment. So they have a first line, the algorithm for first line investigation as well as first line treatment for HMB is by NICE is LNGIUS. However, if the scenario is a young woman who has HMB, but she wants to conceive in next, let's say 3, 5, 4, 6 months, then LNGIS is not the right option. It's a very expensive, as well as it's not the right option if she wants to conceive in a short span of time. So for her, you have to have more flexible choice, like tranexamic acid or maybe cyclical progesterone. So this is applied knowledge, which should incorporate the individual patient's findings and investigation, and then you have a plan which does not deviate from the evidence-based medicine also. So whatever plan you develop, you have to be able to justify that plan in the light of investigation and findings. It may deviate somewhat, they allow that much deviation from the evidence, but you should be able to justify that. We'll just skip that. Now, this was how the exam is conducted and what are the domains which are, how you are assessed. Now, coming to how to prepare. So it's a very high stakes examination. It's a very nerve-wracking examination. You constantly are under a lot of pressure for 3 hours without a break. So you have to have some kind of strategy to prepare. In terms of how many months, I think people will have different opinion, but I think 2.5 to 3 months, minimum 2.5 to 3 months is, if you're motivated enough. If you're appearing directly after part 2 is more than, I think it will suffice, provided you have strategized every aspect of preparation. It should suffice. And Dr. Yasmin knows many candidates who have managed to pass in first attempt in this much time, maybe less than that. I think she managed in less than that time. A lot of mentors also say that if you look at the number of tasks that you should practice or read before you attempt the exam, is mostly will say around 300 to 400 tasks, and that's doable. And you should read all the patient information leaflets. They make you understand the lay language, or the patient friendly language. And I began my preparation by reading patient information leaflet. It's a change from the preparation of part 2, because you get to know a lot, and it helps you in day-to-day clinical scenario also, and in your counseling also. And so one advice is to at least read them thrice, so that those lay terminologies become your second nature. You don't struggle to at the time of counseling with patient friendly language. And then revise the summary of guidelines which are related to the modules. When we say summary, it's like all those bold and highlighted part of the guidelines you have to go through. And relevant TOG articles, at least for the last 1 year or maybe 2 years. And one of the most important aspect, which you will find consistently everybody is advising, whether it is mentors like us who are running online courses, or the MRCOG examiners who have been in the past or who have been part of the examination committee and who have written books, they will say join at least one course, online, offline, join one course. And this applies particularly to the overseas candidate, because we do not know the working of NHS. If they say the best way is to somehow get an attachment as an observer for 2 weeks or 3 weeks in UK, but I think in the current time with kind of travel restriction and pandemic, and it's very expensive. It's not a very I don't know, value for money, but it's not a very cheap alternative. The alternative is joining an online course. In an online course, you won't be, you don't expect to be spoon fed, but we will put you on the right path. We'll keep you motivated, and your finger will be on the pulse of subject matter, because you will be part of a group. And I think if you're appearing for the part 3, I believe that you should put all your efforts, all your resources in getting through the part 3 in one go, rather than appearing again, and because that won't be a financially wise decision to do. And involve your family and friends. Tell them your long-term commitment, and you will need support and reassurance from them. So they have to be prepared. It's a long-haul preparation. Now, how to prepare study resources? I think everybody knows. So patient information leaflets, RCOG, and there are so many case scenarios. Everything has a leaflet. You may not get everything on the RCOG, so you just write down NHS, because different NHS hospital might have a patient information leaflet for a given thing, which you might not otherwise be able to find on other sites. As also, you can look for patient information leaflets on ACOG sites, because you just want to learn the lay terminologies. We will also be sharing what we have compiled, the patient the lay language terminology. We will be sharing that material with you. Then go through all the relevant guidelines, read RCOG informed consent strategy, and also subscribe, if possible, subscribe to the strategy resources. The exam material, it has case-based scenarios that will help you in your preparation. Plus, they have 14 full exam scenarios videos, each representing one module. So you will get a good, fair idea how to prepare and what not to do. So I'm not aware of the strategy subscription fee at present, but I think they are module wise and it's not very costly. You must read few books I've listed, which I have gone through: Oxford, Lisa Joyles, and Justin Cornier. And in between, to relax, you can listen to the Justin Bieber also. Join an online group also, because like Telegram or Facebook, because they will have a lot of people who have sat through the part 3 exam, or you who have passed part 3, because their collective experience will be very helpful in your preparation. The study methodology. So we have talked about long-term strategy. We have talked about the reading material. Now, how to read? First and foremost, I think find a study buddy. It may not be possible to find an ideal study partner, but I think it's okay to have. It's better to have a study buddy that rather than being alone, because it gives you a lot of input. You won't be able to judge yourself from another person's perspective. It doesn't matter how so much you listen to yourself. You need another one's feedback on your task. So look for a study buddy, and if possible, have a small group. I had 2 study partners, one from India and one from UK, and despite our clinic very busy schedule of hospital and different time zones, we were able to study together for 2 hours, almost 4-5 times in a given week. And when you're on your own, then at that time record your audio or video, whatever, record it and then listen. and then reflect what you have to look for subconscious behavior. Like you may, as when I listen to first time to my own task, I notice that I do a lot of okay, something like that. So this is subconscious behavior. You have to overcome that. You have to improve on that. So this is important. And you can meet your study buddy through Zoom meeting, Google meeting. There are a lot of online platforms, and you can share reading material. You can pool your reading material. Study plan, somebody yesterday asked, should we print our study material? I firmly believe in having hard copies, and that's a different kind of experience. You can just organize your study material, print it, organize it, and when you read it, just highlight, so that next time when you want to read, you read only the important parts. That saves time. And set weekly goals, like what do you want to do in 1 week, or set the goal for one module. There are some modules which will take a long time, like maternal medicine is the largest. It takes about 1 week, whereas some modules like early pregnancy problems will take about 2-3 days. So you have to keep a notebook, make a whole plan for the next 2 months, 3 months, or 10 weeks, 12 weeks, what you're going to do, and try to achieve as many as possible. Set a daily goal. Get up in the morning, write down, I have to at least 2-3 tasks, record or with practice buddy, with anybody, on your own. I have to go through 3 patient information leaflets, and I have to go through the summary of 3 guidelines. It's a doable thing. It will take not more than 3-4 hours on a given day, and this much time, I'm sure everybody would agree, is minimum time that is needed if you want to crack it in the time that we have discussed. This is a study plan template. Like if you are going to prepare one module, how to prepare. So for example, let's take early pregnancy module. It will take about 3 days. There are less number of topics. So let's say ectopic pregnancy. First, read the guidelines. Lay stress on symptoms, examination, investigation. That is easy part. Now, expectant management. Wrote down what are the criteria for medical management, what are the contraindications, criteria, and risk. Similarly, for surgical management, look at the recurrence, future advice, and then read the PIL on ectopic, and then apply all this in a clinical scenario. Just go to the record. So you're greeting, you're introducing, you're going through the symptoms, or you're asking relevant questions, and then discuss it with your study buddy. That's just one way to prepare a module or a task. So what's the time? Dr. Yasmin, am I taking too long, because we are just nearing the end?
Yeah. Just go on. And take the cases also. How many slides are there?
Yeah, there is just one case. I have not included more than that because it was going very long. So there is one case.
But you explained this study plan. That will be good, because you are taking very
study plan. So as you go, you prepare, and you reach the last week, I would say slow down. Don't step up your preparation. It will calm your nerves, because this exam is very, very stressful. It's your nerves which are going to get you failed. So if you're able to calm yourself, slow down in the last week. Take off. I didn't take off from my duties, but I was able to manage more hours. So if you're working at a junior level, take off at least from the last 1 week. And instead of reading a lot, start practicing 14 tasks a day with your study partner, and choose one task from each module. So every last 7 days, practice 14 tasks every day. Last night, well, everybody says do not study on the last night. I always do. I can't give up, but it's a different examination. So you have to have a different strategy to prepare last. I'm not saying study last night, just listen to all the recordings, watch videos. It's de-stressing. It will calm your nerves. Reading is stressful. So preparation should be like this. Take a good sleep and avoid any academic discussion with anybody. Everybody behaves in a very different way than the last night. They will be on their edges. Now coming to the course that we are offering, the online course, Beat MRCOG is the baby of Dr. Yasmin Said. She was my mentor in part 2 and part 3, and I'm honored to be associated with her. I've recently joined her. Our objective, as I said, we are not going to spoon feed you. This is about adult learning. We will put you on the right path. We will give you a comfortable, friendly environment where you can practice and your tasks, and we will give you a constructive feedback. This will start in most likely in the first week of September. It has to started in first week of September, and we will go module wise. There will be maximum 2 per week, or we have spaced. I'll show you the tentative schedule, and there will be total 12 sessions which will cover the entire topic, and we will also do the revision. We will take maximum 6 active candidates. When I say 6 active candidates, we mean candidates from whom we expect full participation, that they have to present a case or a task in every session. We will be giving you material before each session, and we probably will also be giving you a scenario, a broad scenario that you have to prepare on this task so that you prepare well. And we will be giving you individual feedback whenever you complete one task. Every individual will be given feedback after that presentation and how to do it in the best possible way. For listeners, we have not set any limit. Listeners means they will be able to attend the course. However, just one person probably will get a chance in each session to present a case. We will try to do that. We will also try to cover a bit of guidelines or algorithms or important topics, but not in too much details. And each session should not last more than 3 hours, roughly between 2 and 3 hours. We also are thinking of then floating an exclusive Telegram group for the course candidates, active as well as listeners, so that we can give one-to-one support to their queries. We'll post some daily activities, we'll share the material, and we will do the exam revision before exam. Session recording will be provided. The fee, coming to the fee, well, the full fee is $600 US, but if you register before 28 August, it will be at discounted price of 500. And similarly for listener, the full fee is 350. The discounted price before 28 is $250. And this is the tentative schedule of 12 session. If we start in the first week of September, we aim to finish the last task by 5th of November, and exam should be somewhere in 2nd or 3rd week, so we will have time for revision as well. This is a tentative schedule, may change a little bit. Okay, Dr. Yasmin, this is the now last 3-4 slides, and I think we are well on time. I would like somebody to volunteer for this task. One more thing before we, I think what I forgot to ask, can we have an introductory session? Just speak up your name and where you're from, which country, which place, and do you intend to appear in November 22 exam? I think that's a fair thing to ask. We'll get to know you better.
Yeah, it's good.
Just one by one, just open up unmute yourself and do we have active part? Okay.
Sir, I am Monica from Chennai.
Okay.
I want to appear in November 2022.
Nice to know you, Dr. Manikam. I know you you volunteer for almost every task, and you're doing really well. All the best for your exam.
Thank you, sir. Thank you, sir.
My name is Hala. Hi, Dr. Shishan.
Hello. Dr. Hala.
Yeah, how are you? I'm intending to appear in next November, inshallah. Hopefully, I can pass this time from first time. Also, I'm planning to be active member with you.
That's great. That's really good to know. And all the best. I'm sure you'll get through.
Thank you very much. I have a long journey with Dr. Yasmin and beatmrcog. Okay, so I do trust her and trust you for sure.
I know, I was part of that group.
Okay, thank you very much.
Thank you.
Hello, sir. I'm Dr. Tasneem from Pakistan, and I wish I would appear. I have planning to appear in Feb if there is a chance, otherwise in May or next November. Most probably not this year.
Okay. So you have begun your preparation well in advance. So you are in for a long haul. Yeah, that's a nice strategy. All the best.
Yes, but also I have a very commitment now. Actually, so I have to find it in.
Yes, sure. We have to, we have to have individual according to our circumstances. Everybody cannot give, X 3 months, every day 4, 5, 6 hours, because we all have different responsibilities. Can we have somebody else introducing themselves?
Hello, sir. I'm Purnima from India. I'm planning to appear in November.
Hi, Dr. Purnima. You are also a regular volunteer in the tasks. Good luck for exam.
Thank you, sir.
Hello, Dr. Shashank. I'm Dr. Vibha from Jayanagar, Madhubani, and I'm planning to take the exam in November 2022.
Nice to know, Dr. Vibha, and all the best.
Thank you. I'm a silent member.
Well, I think, as I said, you should at least join some course. That's, irrespective of whether you join as active or as a listener or a crash course or a 6 weeks or 3 months. There are 6 months course as well. But I think the idea is to, get an idea about how the NHS works from people who have either mentored other people or people who have been there. They have seen it firsthand. All the best.
Thank you.
So can we have a volunteer for this task? Dr. Manikam, Dr. Poonam,
Yes, sir.
Dr. Vibha, would you
Sir,
like?
if nobody is there, please make use of me, sir.
Yeah, sure, please. Please. It's first come, first got type of situation. So would you like me to read out or would you like to read yourself?
I'll read myself, sir. If you want, you can read, sir. No problem.
I can, yeah, I'll read for everybody's clarity. So this station, as I keep saying in my feedbacks, I think, if I forgot to include over here that, you have to strategize your first 3 minutes. They say the, first 1 minute in the booth is the golden minute, that they say, because I say that the first 3 minutes are the golden minutes, because first 2 minutes of understanding that task, I always keep saying, go back, read it twice. First situation, understand the clinical scenario. In second reading, try to decode what they're trying to, is there any hidden clues? So that's how you should. It may take initially 10 minutes for you to understand what exactly they're trying to ask you. Is there any trick? Is there any trap? But as you practice your mind, you will be able to do it in 2 minutes, and that's, I think, the key to passing. That's really important. And then 1 minute of interaction, first 1 minute with the candidate is when you impress them. First 1 minute, as they say, first impression is the last impression. If you are able to establish rapport, if your body language is correct, the candidate will open up. There is subconscious liking or disliking. This may help. So the first 3 minutes. So this is a simulated patient task, assessing info gathering, communication with patient safety, and applied clinical knowledge. You are a ST5 posted in antenatal clinic today. Your next patient is a 19-year-old girl, Monica. She is a primary gravida and she is at 32 weeks pregnant. She's a known type 1 diabetes mellitus case and she's on insulin. She doesn't have any significant past medical or surgical history. She has brought with her the chart of her home tested blood sugar, which all are normal when you see them. However, the nurse is worried as her fasting blood glucose is high, 7 millimoles, and her HbA1c is also very high, 9.1, and they have both been confirmed twice today. Her last visit to joint antenatal clinic, the antenatal and diabetes clinic, was 7 weeks back, her last visit. When her HbA1c was 7.6, as well as her read it FBG was also high, not normal. Her insulin dose was modified at that time, and she was given appointment for 2 weeks later. USG was done today, and report is attached. Blood pressure is this. A urine dipstick mentions no ketones, but sugars are plus. You have 10 minutes during which you're expected to obtain a focused history required at this visit. It's very clearly stating focused history required at this visit. Explain the investigation done today. So you have, it's communication, and formulate a management plan based on the diagnosis and address her concerns. Now you can just go through the ultrasound and single live uterus, longitudinal lie, cephalic presentation, AFI normal, and weight is above 95th centile macrosomia. So if you're ready, just you can take more time, Dr. Manikam, and then you can start.
Sir, I want to ask only one thing, sir. In the growth scan,
Yes.
the name is different, sir. The name has been given
That
Hannah Blair.
yeah, it's a trap. It's just to make you see. It does not happen in the real examination. This just to make you aware that every time you discuss the investigation with the patient, you have to say the opening statement. I've checked your name, your NHS number, and date of birth. This belongs to you. This is just a trap. That's good.
Yes.
In real examination, you will not get this kind of discrepancy. Am I right, Dr. Yasmin? Okay, you missed
Yes,
out.
correct. Yes.
Hello, I am Dr. Monica,
Yes.
doctor in antenatal clinic today. May you confirm your name and age, please?
Hi, doctor. I'm Monica, and I'm 19 years old.
What are you doing? You are a student or
Yeah, I'm studying as well as working part-time to meet my expenses.
how do you want to be called?
Monica is fine, doctor.
Monica. Okay. Monica, today you have come to discuss about you have come for the antenatal visit at 32 weeks. Am I right?
Yeah, you're right, doctor.
What are the concerns you want to discuss today?
I think I'm okay. The nurse was very worried because my tests, blood sugars are not correct. But I have brought I'm doing my tests regularly at home, and they're all normal. But the nurse is saying your sugars are high. Your sugars are high. I don't have as such my concern, but I'm worried. What does it mean? How will it affect my baby or my pregnancy? And what can we do about it?
Yeah, today also the nurse has examined the fasting blood sugar is 7 millimole. She has said that she has confirmed it twice today, and
Okay.
I will keep it. Whatever you say, that will be confidential between you and me. Is it difficult for you to do the blood test so many times? One of my patients used to tell like that. So many times I want to do blood test. It is difficult for me like that.
It is. Yeah, it is. But I still keep to, I keep to the schedule and I keep doing it. Yeah, it is difficult at times with the, tight schedule between studies and work, but I do it.
And do you know the implications of this blood sugar on your condition?
I'm told that it's not very good for the baby, but I don't know exactly, doctor. Can you tell me?
Do you have any do you go to toilet so many times?
I think no. I think that's same.
Do you feel very tired?
Lately, I have been feeling like I'm exhausted. I get tired on doing not very, from previously, my stamina has somewhat decreased. I do feel tired, but I was told that this can be due to pregnancy also.
Have you named your baby?
Yeah, it's John.
John, how John is doing? Is he moving happily?
Yeah.
Good to hear. Have you ever been pregnant before?
No, doctor, this is my first pregnancy.
Okay. Are you up to date with cervical screening? You're sorry, you are 19 years only.
Should I?
I
Am I
thought
supposed to do
it
that?
looked as if it is 29 for it. You are 19. I'm so sorry for
Okay,
this blunder I have made. Do you have any other medical condition for which you are treated by a GP?
No, doctor.
Do you smoke?
Occasionally, doctor. I think I gave up when I came to know that I'm pregnant.
Do you take alcohol?
No, doctor.
So, pardon me. Any recreational drugs?
No, doctor.
I appreciate that you have stopped smoking. Any history of surgery in the past?
No, doctor.
Any allergies?
No, doctor.
Any family history of clots?
No, doctor.
How is the support in the family?
Yeah, I'm living with my parents.
Okay.
And
are you aware of your weight to height ratio? Good to hear. Are you aware of weight to height ratio?
Yeah, I think it's 24.
Okay. Are you aware of your blood group?
Yeah, it's B positive.
Any reservation against transfusion?
No, doctor.
Anything else you want to add to your history?
No, doctor.
Okay. I want to examine you in presence of chaplain with your consent. Thank you for the information you have provided. The specialist nurse will examine the blood pressure, heart rate, and temperature. I want to examine your
doctor,
tummy.
the midwife took my blood pressure before I came to see you.
Okay, it is 110/72. Good. And your but urine shows the sugars are present, and the ultrasound has been done, and the report is attached. I want to examine your tummy and look at the heartbeat, and I want to measure the fundal height from the pubic bone to the top of your womb. But
okay, doctor.
I want to tell you about the report, but it belongs to somebody else. The name is different. It has been written as Hannah Blair, but this is not your report.
Yeah, doctor, the midwife told me that it was a mistake that it got printed. She told me about it and she asked me to tell you about this, that this is by mistake.
Okay. Then this corresponds to the 32 weeks. Everything is similar. Your date of birth is 10 December 2002? Is it?
Dr. Manikam. So it was just a trap. You had to mention it, but otherwise assume it is mine. And so go on.
Okay.
As I said, it won't happen
Monica.
in
Monica, it shows that the baby is single live baby. It is a head is in the down position, and the fluid around the baby is normal, but the baby is showing 95th centile. That is, the baby is weighing. That the baby is one of the 95th of the highest weight of the babies. 95th of the
what does it?
If 100 babies are there, if 95 babies are in the higher weight, your baby is one among them. So the baby has all the abdomen, I mean tummy's diameter, the head diameter, everything will be big. This shows that the baby is big. So it has got some implications.
Isn't that a good thing?
It is not good for you.
The baby is healthy.
The baby is having this develops because of your uncontrolled this diabetes. This as your diabetes is not under control, the baby gets more of insulin entering inside the body, and it goes on growing so much big, and it is not good for the baby. The bones also will become bigger. So I don't want to scare you. There is one already you are under the care of the group of specialists, including the diabetes doctor, consultant, specialist, midwife, and the physician, pain doctor, the dietitian, physiotherapist, psychological counselors, and the support groups are there. You, with your HbA1c now is 9.1, 2, and the fasting blood sugar is 7 millimoles. This is very high.
Doctor,
We have to be admitted.
Doctor, can you? Okay. You want me to? Okay. What is this? Why we are doing different tests? What is this HbA1c?
This HbA1c says the control of blood sugar in the past 3 months. It should be around 6.5, but it is 9.1. And when the fasting blood sugar is 7 millimole, it shows that the body needs more insulin. So the insulin has to be titrated. You have to be admitted in the hospital for observation for some 2 to 3 days by your specialist. He will be adjusting the sugar levels with adjusting the insulin level. That will help you to have a good control.
But doctor, I cannot get admitted, doctor. I cannot get admitted. I have studies. I have my job to do. How I cannot get admitted?
I will inform my consultant. You can talk to her so that she'll be able to provide you sick leave, so that for some 2 to 3 days only, that will be better for your health and for the baby, as now you are only 32 weeks. When you reach 34 to 36 weeks, we'll have a discussion regarding the delivery of the baby with the consultant and specialist midwife. If the baby reaches some 4.5 kg or more, what happens, you'll be offered cesarean section. Is it okay with you? You want
Okay.
what about your delivery plans? Have you anything in your mind, Monica? And
I think no. I want to deliver normally.
So if the baby's weight is more, if now the weight is 3.1 kg, if it goes to 4.5, you'll be offered cesarean section to avoid you getting so many complications are there in the if the baby is big. Is a difficulty in delivery. There is a rare risk of baby dying in womb, and baby can
dying in the womb.
Dying in the womb. That is the stillbirth, we call it. If the baby is big, and the baby can have the chance of instrumental delivery is more, prolonged labor, delayed labor, may require even fixed sort of labor. If the weight is also less, you have a anemic cephalic presentation. Even if you have a fixed sort of labor, the delivery will be prolonged. There is a risk of shoulder getting stuck, instrumental delivery, and the risk of trauma to the vagina and the muscles around the back passage, and risk of cesarean section. And there is a risk of increased bleeding after delivery is also there. You have a risk of clots also is there. I'm not scaring you. This is treatable.
Okay.
You can, and that's what I'm telling. Please don't mistake me. I don't think that I am paternalistic attitude. You think over. If you feel that I am very much scary, I am giving you so much of information. You want to talk? Please tell me. Ask me some questions. Do you have any question? Am I clear so far?
Yeah, doctor.
And you may have infection suddenly. The infection can lead to diabetic ketoacidosis, a condition which leads to admission. I mean, more than time, doctor, sir?
Okay, doctor. I think we have already overshoot well past, but it's okay.
Sorry, sir.
Now let's. No, it's all. That's what. See, it comes with practice, Dr. Manikam. You did a fine job.
Sir. Thank you, sir.
Okay, it was a what is it? Extempore, and let's look at a better way of doing it. So, as I say, that we have to first look at the task, read it twice, and sort of decode it. What do they want? The theme over here is it's a teenage girl pregnancy with it's a poor control of diabetes. But what are the causes? So she's teenage, probably a single mother, maybe studying, could be compliance issues, could be lack of support, could be a lab error, could be instrumental error. So we don't have to be judgmental, we don't have to blame her, but we have to find out what So the theme here is she has been coming. We know she is diabetic. She is on insulin. The theme is poor control with macrosomia. We have to address that issue. So one is why the poor control, and second is already macrosomia has developed. Her sugars are out of control. How to manage that and how to avoid the possible complication. Isn't that? Do you agree?
Yes, sir.
So you started with proper introduction. You greeted, you introduced, you confirmed my name and age. And then you have to, over here, you have to set the scope of this conversation, put the agenda. And you were little off the mark. You in your consultation, you used a lot of medical jargon. That's okay. That's okay. See, it was till now you have been getting time to prepare a task, but you still did better. So how do you explain? So you'll say, okay, I understand, Monica, that you are 8 months pregnant and that you have been coming with, you've been seeing us, and you have, I know that you're from your notes, you're diabetic on insulin, but I have some concerns about your blood sugar results. The nurse has given me your reports, which are done in the hospital, and we have some concerns. I'll share. I'll see. This is very standard that we do. We'll discuss your investigation, your ultrasound scan, as well as these blood tests. But before that, if it's okay, I need to. So you didn't do that. It's okay. Should I ask something about your pregnancy? That's, you missed that. It's just one thing.
Okay.
And it's a very, they have written relevant to the scenario. I think she's a booked case. She's coming. I think regarding her, it is already written. She doesn't have any, significant past medical and surgical history. You need not ask that. So what you did right was, because sugars are high, you asked about polyuria. So you asked about my well-being. Let's come to that. So you did ask about my. So relevant would be pregnancy course so far.
Okay, sir.
You were right. You asked whether she's a boy or girl. Have you named? So you established a rapport with me at that point. Safety point is, are you well? Are you okay feeling right now? Do you feel? You did ask that also. Okay. Her compliance, you did ask, like, are you doing it? Are you having any difficulty in getting yourself, the monitoring the blood sugar? Or what you didn't ask was, how are you storing the insulin?
So in the refrigerator or okay, sir.
Yeah,
Okay.
so we don't have to be judgmental. Yeah, she is teenager, she might be doing this and that, she might not be regular with it. So we don't have to be judgmental, no blame game, but think of every possible scenario. That was one safety tip. She could have how she's storing, how she's injecting, and how does she do her home readings? She's doing and is she having any difficulty in obtaining medicines or using them? If possible, if she doesn't have social support or home support. I recently watched a movie. It's on Netflix. It's called Purple Hearts. You won't believe me. See, it's very difficult if we look at this. Like, is she having problem in difficulty in procuring medicine? Like insulin, it's so cheap in India. It's so cheap. I saw this movie on Netflix, Purple Hearts. There is this girl who works in a restaurant and she's diabetic, and she's finding it difficult to buy her insulin. It a single vial, or it's costing somewhere around $300. So its scenario is different over there. So you have to ask this also. And then, isn't it? And then there are some routine details which you did ask, but I'm sure because it's a follow-up. She's booked follow-up visit. There are some things which are already established, must be there in her notes. Okay, social support you did ask. And now coming to explaining the results, I think you over there you use a lot of jargon.
Okay.
We could have started with the okay, let's start. We should first start with her sugar control, because that's what is concerning. So you will tell her that, see, I see that you have done your blood sugar charting and they are normal, but we have done 2 more tests. One is HbA1c. We check it to look for the sugar control for the last 3 months. Normal is this much, US is high, that means it is not controlled. And you will say that possibly it could be a lab error, but we have checked twice. It could be an instrument error, we'll look into that. But we also did your fasting blood sugar, that is also high. So tell her that it could be storage problem, it could be that your home glucometer is not calibrated. So don't blame her.
Okay, sir.
Give her scenarios. And at the same time, you have to sort of highlight the importance of sugar control, which you did, but it should be in a non-scary way. Like what can happen? So macrosomia, you have to, this is where you need to work on. You can think of something in simple language, like when your diabetes is not controlled, your sugar levels shoot up, and then they got, they crosses over to the baby's side, and the baby's blood sugar will go up, and to control it, the baby will produce more insulin, and it is the insulin which causes baby to grow more in size. And as we have seen, the baby's weight is this much, and we plotted it on the graph. Now show it, point it on the graph. Try to show that you're showing point that we have plotted it on the graph. Now explaining, instead of 95th centile, that's a medical jargon. Say that there are these two lines. If the weight is following this dot, your baby's weight is, or say John, now you know the name, say if John's weight is, it falls between these two lines, then it is good. However, John's weight is above this line. So it means that your sugar were uncontrolled. And if it remains uncontrolled, then the baby is going to get more bigger, and it might cause problem for you and for the baby. Say something like this. Then she'll say what it can cause. So then tell her that having a large baby can cause problem during pregnancy, during delivery, and after the baby is born. So what can happen, as you said, the fluid around the baby can be, a lot of fluid can accumulate around the baby, can cause, you can have a premature delivery, and then you said the baby will die in the womb. So it's okay, but I think that's a very sensitive issue.
For a small girl, it's not safe.
What you can, for anybody, I think it's a very scary to say your baby might die in the womb. So don't use the word die. We can say that the sugars can harm your baby's heart, and it can make the heart stop. That is sort of signposting. She will understand what does it mean, isn't it? That's how that's the mechanism how the IUFD occurs. Then during delivery, the shoulders can get stuck. It can cause baby's harm to the baby's nerves, and can affect it can affect arm or hand movements. The baby's collarbone might get fractured. You might have tear around your vagina. You might have to do cesarean section, and all that you did explain, but it's just that brief and in patient-friendly language. That's the crux. And then management. So this was about explaining results and the risks of uncontrolled diabetes. Now management, of course, sugars are high. The ketone is not there, but if she goes back, it seems there is some issue with the sugar control. So you have to admit, there is an indication. You have to admit her for blood sugar control. So now you need to negotiate with her in a very non-scary way. She might say, I have this and that. So you did that part rightly. You said, I'll ask my consultant to talk to you. Okay, so that was the correct thing that you did. And then once you're admitted, you will be looked after by specialists on diabetes team, and they will try to control your blood sugar by changing the insulin dose. And then you probably explained also that as the pregnancy advances, the dose may need to be increased. And we'll watch, you have to watch out for baby movements, and then we will repeat the scan after 2 weeks. And then around the delivery plans will be discussed. So you went too much in detail, which probably is not required at this moment. In 10 minutes, you cannot, you cannot complete everything. So what is relevant at this moment? The relevant thing is to admit her, to tell her what, how you're going to manage her. And if she does not agree, to sort of engage her, negotiate with her in a non-scary way, involve your consultant. And if she still is adamant she won't, then you say, okay, I'll put you in touch with the diabetic team, and I'll ask them if it is possible to manage you on outpatient basis. So you can't totally negate. It's patient's autonomy. So you have to find the middle path. Okay.
Thank you, sir. Thank you for your good advice, how to talk. Thank you, sir.
No, it's thank you so much. And so this brings us to the
thank you for the opportunity, sir.
You're most welcome. You actually grabbed the opportunity. It was for everybody to. So you should not be take up, practice as much as you can. We all have been through this phase. We all used to get stuck. So it's the practice. Speak up, record. So thank you and best wishes. We all can do it. See, I was in London and I went to Sussex Park. I'll just share my experience with you. I was 7 years back. I was there for a brief fellowship in oncology, and I was staying in YMCA. It's in the heart of London, and Sussex Park is a walkable distance. And Sussex Park, where RCOG was there. Right now, I think nowadays they have shifted from there. I met 2 candidates. One was from India, and he was appearing at that time. Part 3 was conducted only in overseas. It was not conducted in India, and this guy was coming for the 3rd time for part 3. Look at the motive. I was amazed. I had just done part 1 and I'd given up. I thought that it's too difficult. I won't be able to do it, so I'd given up on doing MRCOG. And then I met this guy. He said, I took 4 attempts to pass MRCOG part 2, and this is my 3rd attempt in doing part 3. And he was a junior person at that time, but look at the kind of money involved, and he was determined to do it, and he did it in that. He took me to the Sussex Park and said, let's click a photograph. We clicked a photograph, and I thought, I will not be able to do it. This guy is not able to do it in 3 terms. I'm definitely not going to do it. But he got through, and then later on, I don't know what kicked in me, so I appeared in part 2. I did it in second attempt, and I did part 3 in first attempt, sorry. All thanks to Dr. Yasmin. She has mentored me.
Super, sir.
So thank you so much. And we would be asking the feedback. You'll get a mail about the session. Please do find time to fill the feedback. Thank you so much. Dr. Yasmin.
Yeah, Dr. Shashank, it was very nice and elaborative. Your lecture was very good. Everyone read the patient information leaflet fast. So you will be well versed to speak in the lay language, because this is must to pass this exam. And Dr. Shashank had given you the tips. It's very good that how to prepare. That was very good. That is the 3 cases daily and 3 GTG. So start with this and then increase, and listen Justin Bieber. That's what's good.
Yes.
Justin Conway.
Justin Conway and listen Justin Bieber.
Yeah, really it's needed, because this exam, when you will reach nearby exam, the tension is very high. Because I was counseling myself that time, that when I was giving exam, I was telling, if I fail, I'm not going to lose anything, because I'm not going in UK. So that is extra. Yes. But I know the tension we have that time. So start studying from now only, and don't think. And revision is must in this exam. At least 3 times, as Dr. Shashank told you. Because we forget. If you will, even you have done at that last day also, I'm also reading everything. I'm also revising everything on last day. I'm not telling my student, don't do anything on last day. So revise and revise. Even weekly revise. If you have done 2 modules, after 2 weeks, revise that cases again and again. So you will not forget. And first thing, it's very important. The case was given by Dr. Shashank was very difficult. It's a 19-year teenage pregnancy with diabetes, not controlled, and polyhydramnios and everything. And you have to address everything. And she will ask you so many questions in this. So the case was very good. So prepare this case, record, and put again in the group. So Dr. Shashank will give you the feedback. So all the best. And if you want to join us, please join. Okay, good night.
Good night.
Good night.
Okay.
Good night. Dr. Shashank, it was very great session. Very good.
Thank you. Thank you, Dr. Yasmin.
Okay. So we'll finish.
Yes, we'll just stop the recording. It's not getting.
This conference will now be recorded.
Okay, we'll end the meeting.